Hi, my name is Cheryl Moore. I'm a student physical therapist at St. Augustine. Today I will be evaluating a patient with right low back pain. I will start with her patient history, followed by tests and measures, and then get into some interventions for her impairments. According to Franca et al. In 2012, Journal of Manipulative and Physiological Therapeutics, they found that chronic low back pain affects about 50% of the adult population and lasts at least 3 months. It is also expected that at least 70% of the adult population will have low back pain at least once in their lifetime. So the purpose of this presentation is to eval a patient and to identify how her right low back and SI joint are causing her pain. The patient is a 66-year-old female. She was out camping, reached onto the bottom shelf to pick up a heavy box. She bent, lifted, and twisted. She felt a pop and burning sensation in her back. She does not recall if she had radiating symptoms. However, she does remember that she had difficulty walking up and down the stairs. Her current chief of complaint is having difficulty standing back up after she bends over, and sitting with her legs crossed for long periods of time also causes her some low back discomfort. The patient ranked her pain using the NPRS scale, which was validated by O'Haran et al. In 2013 International Journal of Sports Physical Therapy. She rated her pain a 2 out of 10, with 0 being no pain at all and 10 being so bad that she has to go to a hospital. However, she told me that the day before it was a 6 out of 10, but she thinks that's because she got a massage earlier that day and she had a flare-up. She also states that she's been having more and more flare-ups recently, but she thinks it's due to training for a half marathon, which she finished the previous Sunday. Her best pain is a 0 out of 10, and that's when she's laying down. Her worst pain is a 5 to 6 out of 10, and that's usually in the evening. She did go to physical therapy for this about a year ago, and it made her symptoms better. However, she has not returned, and her symptoms have come back. She has no imaging, and it takes a couple of leave when the pain gets really bad. But other than that, is not taking any medication. The patient has no significant past medical history. So the patient was given the FABQ, Fear and Avoidance Belief Questionnaire, which was stated by Tahero et al. In 2016 in the Scandinavian Journal of Pain as a valid 16-question self-reported questionnaire, which measures fear and avoidance of physical activity and also work activity due to pain. The patient scored a 22 out of 96, which indicates she's only moderately afraid to do activities. The patient will be given this FABQ again upon re-eval so that we can measure her perception of her pain. The patient's goal is to be able to get dressed in the morning. She has difficulty bending over and then trying to get back up, and that makes getting dressed or doing her ADLs very difficult for her. So upon initial assessment, the patient had forward head posture, and she had a very flat back. She had no kyphosis or lordosis of the thoracic and lumbar spine. The patient's right iliac crest and right trochanters were higher on the right than on the left. The patient's right PSIS also sat lower than her left PSIS. All other landmarks were unremarkable. The patient's active range of motion was full in all directions. However, she did feel pain with forward bending in the L3-4 area that she normally feels, and she had difficulty getting back up using her hands on her thighs to walk herself back up, which is a positive Gower sign. The patient also had a slight hinge on extension, and again, pain is felt in that normal 3-4 spot, L3-4. The passive mobility testing of the thoracic spine found that it was hypomobile in T4-5 and T8-9, and lumbar spine in the L1-2. She was hypermobile in her lumbar spine at L3-4, and her right SI joint was hypermobile in posterior rotation and hypomobile in anterior rotation. She had tenderness with palpation over her right sacroiliac joints with moderate pressure. Her right hip internal rotation was 20 degrees above normal, and her external rotation for both right and left were limited by 5 degrees. Her MLT for hamstring tightness on the right was 10 degrees less than that on the left. Her Thomas test was also tight for the 2 joint muscles, rectus femoris, but normal for her 1 joint iliopsoas muscle on the right. Her left was totally fine. The MMT for back extension and hip muscles were all normal strength. The patient's abdominal strength was weak when she performed the double leg lowering test, in which the patient was laying supine, and I asked her to bring her legs from 90 degrees down slowly to the mat while maintaining correct back posture. The patient was only able to get down 60 degrees, so she's weak. Her upper and lower quarter screening, neurovascular screening, and slump tests were all unremarkable. The patient had a positive lag test on the right, in which you palpate the PSIS in the back and have the patient bend over. You're assessing mobility. In this case, with the patient, her left PSIS moved before her right, so her right lagged, and that was a positive test. The patient was also positive for an axial load test, in which a load was pressed directly down onto her shoulders, and there was banding at the level of 3-4. She was also positive for the aberrant juddering test, in which I held on to the patient's hips. She bent over, touched her toes 3 times, and came back up, and there was juddering or like little flickering movements of her muscles around the L3-4 area as well. The patient's supine to sit test was also positive, in which I had the patient lay down on her back, bridge up, extend her legs, and then I assessed where her malleoli, her right malleoli and left malleoli were from each other, and then I had the patient sit up and then reassessed again. In this patient presented with right malleoli that moved closer, that was shorter when she was laying down and moved longer when she was sitting up. This indicates that the patient has right posterior rotation of the SI joint. All other lumbar instability and SI joint special tests were negative. However, the patient did report that ASIS compression made her pain feel better. So based on the patient history and the tests and measures taken, I would have thought this patient was an instability patient. However, because she presented with 4 out of the 8 clinical signs, however, she did not fall into the Hicks CPR rules. So this patient is just hypermobile, but is very at risk for becoming unstable. So her ICF classification is low back pain with coordination mobility deficits, especially at that L3-4 area, because that's where her pain comes from. So prognosis for this patient is good. She is active, healthy, has no comorbidities, and she's willing to do her home exercise program at home. Long-term goals are within 1 month, the patient will be able to bend forward and stand back up without using her hands, so that she can do ADLs and put on her pants without having too much pain in the morning. So impairments, I would like to treat the hypermobility at L3-4 with stabilization, focusing on the local musculature, the transverse abdominis, and the multifidus. In a study by Torbeck in 2007, the Journal of Rheumatological International looked at the effects of 8-week lumbar stabilization program, and they found that it was good for general pain relief, trunk muscle weakness, and postural impairments. I would then like to treat her T4-5, T8-9, and L1-2 hypomobilities with grade 4 MOBs. In a review by Gortz et al. In 2012, the Journal of Ectomyelopathy and Kinesiology compared 38 based articles, and they found that high velocity and low amplitude mobilization provided the same treatment benefits as other conservative methods. I would then like to address her hamstring tightness by stretching her hamstrings. In a study done by Fusili et al. In 2007, Journal of Body and Movement Therapies, found that hamstring length was usually very much so decreased in low back pain, and it also caused the pelvis to tip backwards relatively quickly. So I'd like to stretch that out and decrease the amount of time before the pelvis starts to rotate backwards. I would then like to address her right posterior pelvic tilt by performing an anterior manip, grade 3 and 4. And then I'm going to address her hypomobility of her SI joint with stabilization. In an article by Schwimmer and Jafarian et al. In 2013, the Journal of Musculoskeletal Pain, it looked at the effects of compression and muscle activation in 6 specific muscles: the rectus abdominis, gluteus maximus, adductor longus, internal, external oblique, erector spinae, biceps femoris, and they noticed that compression decreased the muscle activation in all of these muscles. So what I would really like to do is focus on the transverse abdominis and the rectus abdominis in this patient, try to stabilize her core and to get those ASIs to come back together and to decrease the amount of muscle strain. So to sum my findings, this patient has hypomobility, hypermobility of the thoracic and lumbar spine and SI joint, and I would like to continue with the stabilization program, manipulations, and stretching to help this patient achieve her long-term goals. This concludes my presentation. Thank you. Any questions?